Hello, my name is Jina Chung, and I'm an assistant professor of dermatology and dermatopathology at University of Pennsylvania. And today I will be giving you a talk on cutaneous lymphoma for newly diagnosed patients. I do not have any relevant relationships with industry. So I thought that it would be good for us to kind of go over this talk in a way that often kind of mirrors what patients ask me when they come see me in clinic for the first time. So it is question and answer based. So the first question is, what is cutaneous lymphoma? And a lymphoma is basically a cancer of the lymphocytes. And a lymphocyte is a type of white blood cell that is found in our immune system. So this is an example of a lymphocyte, what it might look like in your blood. These are your red blood cells. And then a lymphocyte can have different types, including T cells, also known as a T lymphocyte, and B cells, also known as a B lymphocyte. And lymphocytes are in our circulating blood, and they're also found everywhere in our body, including skin, lymph nodes, spleen, and other organs. So what's cutaneous lymphoma? So in cutaneous lymphoma, the lymphocytes that typically reside on our skin have become abnormal. And cutaneous lymphoma can involve either T cells or B cells. And cutaneous lymphoma can actually have a very wide variety of presentations and can look like rashes, tumors, and you can just have widespread itching or just redness of your skin. So this is just to show you the wide spectrum of cutaneous lymphoma. So it can look like a rash. So you can have kind of these patches that are scaly on your body. And people might say, oh, you have eczema or psoriasis. And then later you get diagnosed as cutaneous lymphoma. And you can also get ulcers. And you can also have kind of raised nodules. And sometimes they may present as light spots without any redness, or sometimes you can get something called erythroderma, where you just get this generalized redness without any patches or plaques. So there are many different types of cutaneous T-cell lymphoma. So this is just a list of the WHO classification, which is from the World Health Organization. And the most common type of cutaneous T-cell lymphoma is mycosis fungoides, also known as MF. And this is the most common. You can see this comprises about 40% of cutaneous T-cell lymphomas. There's also Sézary syndrome, which is kind of when the T cells are in your blood are abnormal. And then you also have many other different types of T-cell lymphomas. So cutaneous T-cell lymphoma does not necessarily equal mycosis fungoides, but mycosis fungoides is the most common type of cutaneous T-cell lymphoma. And this is a list of the types of cutaneous B-cell lymphomas. And you can see it's a much shorter list than cutaneous T-cell lymphomas. But the general takeaway here is that there are many different types of cutaneous lymphomas, and your treatment and prognosis depends on what kind of lymphoma you have. So how is cutaneous lymphoma diagnosed? So usually the first step is a skin biopsy. So this allows us to look at our skin under the microscope. So typically what happens is that when you have a weird rash that's not getting better, it's very itchy, or you have a weird raised nodule that's not going away, you typically go to your dermatologist, and then the dermatologist numbs up your skin and takes a little sample and then sends it to the lab. And then when the skin biopsy looks atypical, this is typically the first step that alerts us to the possibility of cutaneous lymphoma. And when you get diagnosed with cutaneous lymphoma, you might need additional blood tests, including a complete blood count and a comprehensive metabolic panel. And then depending on the stage, you might need some optional additional tests that includes a flow cytometry of your blood. And this is a test that helps us look for circulating lymphoma cells in your blood. You might need additional imaging tests such as CT or a PET-CT. This is not always needed, but depending on your stage, your doctor may recommend you to get this. You may need a lymph node biopsy if your imaging test, such as CT or PET-CT, shows anything abnormal. And then sometimes you also do gene studies to see if there's a population of genetically identical lymphocytes, also known as clonal lymphocytes, in your skin or blood. Because when you have cancerous cells, they typically clone themselves. So if you can find the same clone of the T cell in different sites in your skin, this can be very suggestive of cutaneous T cell lymphoma. So your stage depends on the extent of your skin, lymph node, and blood involvement. So this is how we staged mycosis fungoides and Sézary syndrome. So T1 is when you have patches that are less than 10% of your entire body surface area. T2 is when you have greater than 10%. T3 is when you have raised tumors that are greater than a centimeter in diameter. And then T4 is when you have generalized redness of your skin without any normal skin left, also known as erythroderma. And then we take a combination of your T stage, which is your tumor stage, and then whether you have any lymph node involvement or whether you have any organ involvement or whether you have any blood involvement. So we take a combination of all of these factors to decide your overall stage, which is on the left-hand column here. So another question that patients often ask me when they come see me is, why did my disease take so long to get diagnosed? And I know that this is something that is very frustrating for many patients, so I wanted to kind of discuss that here. So the average time to diagnosis in mycosis fungoides is 4 years. That's a very long time, and often multiple skin biopsies are needed. And there are many reasons for this. And part of the reason is that, as we saw earlier, cutaneous lymphoma can present in a wide variety of ways. And it can mimic other rashes like psoriasis, eczema, drug rash, chronic wounds. And it's not just for the dermatologist. This is also true for the pathologist. So when we look at cutaneous lymphoma under the microscope, it can mimic eczema, it can mimic psoriasis, and there's no single reliable test to tell us whether it's lymphoma or not. And unfortunately, blood tests are often completely normal in early stages of mycosis fungoides. And you can also see genetically identical lymphocytes in other conditions. So while I said that, if you see the genetically identical lymphocytes, this can be suggestive of cutaneous lymphoma, this doesn't always mean that it is lymphoma. So even if you have clonal lymphocytes, sometimes you can see that in other conditions like eczema or psoriasis. So it doesn't necessarily mean cancer. So I thought that as a dermatopathologist, I might show you kind of what skin looks like under the microscope. So this is an example of what normal skin looks like under the microscope. So if I took a sample of your, uninvolved normal skin, it would look like this. So this is the epidermis, which is the topmost layer of the skin. And then this is the dermis, which is underlying the epidermis. And then you have some blood vessels because, you're human. And then you also often have a little bit of inflammation in your skin, and this is normal, but you shouldn't have too much. So this is what a biopsy of someone with mycosis fungoides should look like. So you have the epidermis and dermis again, but you have all these little black cells, and these are atypical lymphocytes, and they're dark and enlarged and hyperchromatic, and they're lining up along the junction between the epidermis and the dermis. And they're also going into the epidermis, which is very abnormal for a white blood cell. And then they're also in the dermis too. So when I see this, I can confidently say, this looks like mycosis fungoides, and I can diagnose you on the spot. But this is actually what I often see. So here we have the epidermis and the dermis again, and then you have a few white blood cells in the epidermis, but not a lot. And it's just not enough to get to that diagnosis. And sometimes this is even what I see. I have like 3 white blood cells in the epidermis here, and the rest of it looks pretty much like normal skin. And at this stage, we can do the gene studies to look for clonality, but it's often negative at this early stage. So what's really surprising is that all 3 of those biopsies were actually from the same patient, obtained on the same day. So this should tell you that there can be such a wide variety, even obtained at the same time, in biopsies of mycosis fungoides. And because of this first specimen, I was able to make the diagnosis of MF. But if I had only received the second one or even this third one, I would not have been able to arrive at that diagnosis. And I would have had to have additional samples in order to reach that diagnosis. So what happens in the meantime? Patients often ask, well, if I don't get diagnosed, then I'm not getting treatment. But that's not necessarily true. Delaying treatment does not necessarily mean delaying care. And the nice thing about early MF is that treatments are often the same as other conditions such as eczema or psoriasis. So we often treat early MF with topical steroid creams or UV light therapy, or even oral methotrexate, which is a pill that you can take. And in unclear cases, we can initiate treatments that can be helpful for multiple conditions, including MF. And there's no evidence to show that earlier treatment prolongs survival, so a wait and see approach is also reasonable. And a clear diagnosis can sometimes take years and patience. So what caused my lymphoma? Patients often want to know this. Unfortunately, we do not really know what causes cutaneous lymphoma. We do know that it's an acquired disease, so it's not inherited. So just because you have MF does not mean your children will have MF. There's no specific genetic test that we can do to see if you have MF or to see if you will get MF. There's no clear association with diet, environment, or infections such as COVID-19. And we do know that it's not contagious, so you don't have to be worried about giving it to someone else. So another common question that patients ask is, should I see a dermatologist or an oncologist? And this is a very good question. So the early stages of mycosis fungoides or cutaneous T-cell lymphoma can often be managed by dermatology. And this is because many skin-directed therapy options, such as UV light, are often available in dermatology offices. But in more advanced stages, when you have tumors or you have lymph node involvement or blood involvement, then oncologists and dermatologists work together. And this is because usually IV treatments are typically given in an oncology setting. And even the patients who are on IV treatments will often still need skin-directed therapy like the UV light. So patients will often continue to follow with dermatology as well. So that's why in many treatment centers for lymphoma, you have multiple specialties working together to deliver care. So this is a really nice way to look for treatment centers close to you. So on the Cutaneous Lymphoma Foundation website, if you go to patient resources, this actually allows you to put in your location and look for lymphoma treatment centers that are closest to you. And if you look for Philadelphia, this is an example of what you might find. You might find a page of this is the Penn Cutaneous Lymphoma program. And you can see how to contact our patient coordinator so that you can get scheduled to be seen. You can see the types of treatments that we provide, including radiation treatment. And you can see the list of doctors, so it includes myself from dermatology, as well as other dermatologists, oncologists, and radiation oncologists. So what is my prognosis? This is a really good question. So it depends widely based on the type of lymphoma that you have and the stage. The nice thing about early stage MF is that patients who have stage 1A, which is the earliest stage, will typically have excellent prognosis. So when you have stage 1A, that means that you have thin patches that involve less than 10% of your body surface area without significant blood or lymph node involvement. And typically those patients will only have a few spots, and those patients have identical long-term survival as the general population. And aggressive treatment does not necessarily affect survival to our knowledge. So this is a graph showing the overall survival in mycosis fungoides. As I said before, stage 1A patients have the same survival as the general population, so they're not shown here. But you can see that starting from stage 1B, survival does get worse depending on your stage as you get to stage 4. I will say that there has been significant improvement in disease-specific and overall survival when you compared from the 1970s to 2010s. So it's been improving each decade. So if you look at this graph, you can see that this red line is survival of MF patients from the 70s, and it was significantly worse. And then the blue line is from the 80s, The green line is from the 90s, the purple line is from the 2000s, and then the orange line, which is cut short because this study was only until 2016, is still better than the purple line. So this was statistically significant. So what this tells us is that prognosis is improving for all MF patients. And this is partly due to some changes in the way we classify cutaneous T-cell lymphoma. Before, in the older studies, some more aggressive lymphomas were categorized as MF, but now they've been classified as a new disease, so they're no longer grouped with MF. We've also had many new therapies for MF, and there's also been significant improvement in infection control and antibiotics because cutaneous lymphoma patients are susceptible to infection. So will early stage MF eventually progress to advanced stage MF over time? This is another excellent question. And the good news is that most cases of early stage MF will behave as an indolent chronic disease. And most patients with stage 1 will stay in stage 1 during their lifetime. There is a small percentage of patients, about 5 to 25%, depending on your resource, may progress to more advanced stages. And there are some factors that can be associated with an increased risk of progression, including older age, higher stage at diagnosis, and whether you have some large atypical cells on your biopsy, which is called large cell transformation. I will say that an important point is that having the disease for a longer time does not necessarily mean higher risk of progression. So younger patients are often worried because they're like, well, I'm 20 years old. I'm going to have this disease for a long time. Does that mean that I'm going to progress? That's not necessarily true. Younger patients actually typically have a more favorable prognosis. So how do I know if my MF is spreading to inside my body? And this is something that makes patients very nervous. So MF will usually show obvious signs of progression on your skin, such as tumors, worsening ulcers, or that generalized redness of your skin that is known as erythroderma before going into your lymph nodes or your internal organs. And sometimes patients can get some more patches or temporary flare, but this does not necessarily mean it's progressing. And MF can actually wax and wane over time, similar to eczema or psoriasis. So you need to be regularly monitored by dermatology who can actually monitor your disease and say, yes, this is progressing, or no, this is okay. And some patients with blood involvement, such as patients with Sézary syndrome, are followed by routine blood tests, such as a flow cytometry, which is that test that we discussed that helps you look for circulating lymphoma cells in your blood. But follow-up blood tests are typically not indicated for early stage patients without blood involvement because they're usually normal. So what kind of treatments do I need? So it depends on your stage. So treatment options for early stage patients can involve skin-directed therapy, which is, I would say, the mainstay of treatment for early stage disease. And this includes topical creams like topical steroids, and there's also creams like nitrogen mustard and retinoids and imiquimod. You can also get UV light therapy, which is very helpful for early stage disease. Or rarely, if you have only 1 or 2 spots, you may be able to get radiation therapy. Sometimes if you have too many spots and you're not responding well to skin-directed therapy, your doctor may recommend systemic therapy options like retinoids or methotrexate or interferon, which is an injectable medication. If you have more advanced cutaneous lymphoma, typically this is at a stage where dermatologists and oncologists will work together to provide treatment. But there are many treatment options for advanced stage lymphoma as well, including brentuximab, romidepsin, pralatrexate, mogamulizumab, which is a new treatment that was recently FDA approved, photopheresis. Rarely, patients may even need chemotherapy, and very advanced stages of patients may ultimately need bone marrow transplantation. And there are many other treatments on the way. So this paper is from 2021, and this is just a list of the many clinical trials for cutaneous T-cell lymphoma that were in process 3 years ago, and now there's even more than this. So this should tell you that new treatments are definitely on the way, and we are actively working on finding better treatments for CTCL patients. So the goals of treatment include improvement of quality of life. So as I said before, aggressive treatment does not necessarily improve overall survival. So we focus a lot on quality of life and your symptoms. And we try to regularly monitor you for progression. And we also want to minimize long-term side effects from treatments. Because early stage MF is such an indolent lymphoma, the treatment should not be worse than the disease. And sometimes we can't get to 100% clear skin, and this is okay if you are comfortable. The only cure is a bone marrow transplant, which has significant risks, such as graft versus host disease. And recurrence can still occur even after a transplant. So we only reserve this for very severe advanced cases. And for all treatments, we have to weigh the benefits against the potential risks. So I want to touch briefly on cutaneous B-cell lymphomas because most of my talk has focused on T-cell lymphomas and mycosis fungoides. Cutaneous B-cell lymphomas are typically diagnosed by a skin biopsy similar to T-cell lymphomas, and you will probably need a workup including a physical exam, some blood tests, and imaging tests such as a PET-CT or a CT scan. Some patients with aggressive types of B-cell lymphoma will also need a bone marrow biopsy, but this is not true for all B-cell lymphomas. And your prognosis and treatment depends on the type of lymphoma that you have, similar to T-cell lymphomas. There are more indolent types of B-cell lymphomas like primary cutaneous follicular lymphoma and primary cutaneous marginal zone lymphoma, which can be actually treated with excision where we just cut out the lesion, or you can get radiation, or sometimes we can actually do creams, or we can inject steroids directly into the lesion. And sometimes, since it's such an indolent lymphoma, we don't do anything and we just kind of watch and monitor the patients. If you have more aggressive types of B-cell lymphomas, like diffuse large B-cell lymphoma or intravascular large B-cell lymphoma, then you would need to follow with oncology to get chemotherapy, sometimes a treatment called rituximab, and you may need radiation therapy as well. So treatment and prognosis varies widely on the type of lymphoma that you have. I think that this is a really helpful patient resource. I love the Cutaneous Lymphoma Foundation. I think they have a lot of good information for patients. The National Comprehensive Cancer Network also has patient information. This is a booklet that they made in 2021 that I often kind of show my patients too, and it includes information on both T-cell and B-cell lymphomas. Some take-home points. So diagnosis of cutaneous lymphoma can take years. And given the challenges in diagnosis and treatment, you should never be afraid to seek a second opinion. And many skin-directed therapy options exist for early stage cutaneous lymphoma. And patients at this stage can typically be managed by dermatologists, while advanced disease patients typically will need multidisciplinary care, including oncology and dermatology. And your prognosis depends on the type and stage of your lymphoma, but survival is improving over time, and many new treatments are on the way. Thank you.